Okay, so that's my white tape. And I want my brown tape to go right over that.
Are you putting the manually?
When I do the white tape, I don't do anything. He doesn't do anything. So white tape is just positioning. It's just like when you do your McConnell taping. You just put it on so we don't torture his skin when we, you know, because the brown tape can be not very forgiving. Just size that up.
Would you want someone to be pushing back on the fibula while you do this?
You could do that. You could do that.
Let's get it done.
Or I can just do it myself. So,
You always do this in weight bearing?
I do this in weight bearing. Do you not do it in weight bearing?
Right.
So you will do it in non-weight bearing?
Yes.
Okay.
Yeah.
So I'll do mine and then you do yours.
Okay.
Okay, we'll do that. All right. So what I'm going to do here, now I'm going to take the fibula and I'm going to try to push it back. Okay? You okay?
Yeah, it doesn't hurt.
And as I do that, I'm pulling the tape across. Okay?
How long do you keep that on for?
He could wear the tape for a couple of days, and then he can take it off. Taping is not, you know, the only time you take, now how does that feel? So you've got more mobility? So let's see how you squat. See how his squat and his dorsiflexion is better? Go ahead and squat.
More smooth there.
Yes, but he's good. Where do you feel this? Still in the front? Yeah.
Yeah, so right here.
Okay. How far can you dorsiflex on the left? Okay, and let's see how you do on the right. And we've got at least a 50% improvement here. So that I would be happy with fibula back.
Right over the...
Yep. Now go ahead and invert. Does that not hurt? Okay. Oh.
Right.
So isn't that interesting? That kind of is, Brian Mullen would be like, yeah, it's exactly what I'm talking about. Because
Yeah, of course it does.
he says, of course it doesn't hurt. Because what happens when he inverts? What happens to the distal fibula? It gets pulled forward. So Mulligan is saying that the reason he's having pain with this is because he doesn't like his fibula being pulled forward because it's already pulled forward. So Mulligan is saying, well, I'm going to just push it back. And now you go in.
There's a little less.
Hurts
It still
less.
hurts, but...
Yeah, okay. So, you know, that might disprove the theory that this is just the anterior talofibular ligament. Because if it was just the ligament only, the movement would hurt regardless of where his fibula is. So this is kind of a Mulligan
Yes.
concept, right?
Mm-hmm.
Sort of?
Yeah, positional fall.
Yeah. All right, about 90 degrees. So go ahead and lie flat. Okay. And we're going to bend the knee up. Oh, that's perfect. Put it right in here. You could use a towel or a pillow. Lift up. Okay. And what I'm going to do is I'm going to say, hello, tibia. Okay? This is how I do it. Hello, tibia. I'm going to push his tibia back, okay, with one hand. The other hand, all right, well, let's look at his range first. We always want to do that. So let's just compare. Let's just look at how he is with plantar flexion, because obviously you guys want to see. I want to see if it's going to work. Go ahead and plantar flex.
Oh.
As much as you
Oh my God. What about with your knees bent?
No, there's not a two joint. You know what I mean?
Well, with the gap, when you gap strong across, it's very distorted.
All right. So, go ahead and plantar flex as much as you can. As much as you can. It's not terrible. It's not bad. It's actually not bad. But let's, it's horrible. So let's get your leg up. So what we're going to do here is we're going to push the tibia back. I'm going to push his tibia back, and I'm going to pull his foot anteriorly, or as the talus anteriorly. I want to roll the talus anteriorly. So like you guys would have done, concave convex. If you were going to increase plantar flexion, how would you do that? You would have the patient prone and do your anterior glides. Well, this is essentially an anterior glide. So I'm going to plantar flex him. Now, this is a technique we are not going to see a lot of movement here. So, for example, let me show you on this leg. This is the wrong way to do it. Hop up or bend this knee up. This will be the incorrect way. Okay. Lift up, and I'll just put this in. A lot of times you might want to use a pillow. When I push his knee back, or his tibia back, what that does for me is it gets his ankle in 90 degrees of dorsiflexion. So I want 90 degrees here. And if I'm not pushing hard enough, he's not going to be there. So I push this back, he's at 0 degrees, I grab the talus. And while I'm pushing, what I want to do is I just want to do this, where I roll the talus forward. If you guys feel like you're doing this, okay, you're not plantar flexing his foot. You're just grabbing the talus and just pulling it forward a little bit, okay? Does that make sense? If you're seeing a lot of movement where you're coming down like this, that's excessive, okay? That's too much. So we're not looking for a physiological motion here. We're looking for an accessory motion, okay? So let's see how we do. This is Mulligan's miracle technique. And I have to tell you, I just had to laugh. The first time I did this on a patient, I was very hesitant to do it, but I did it. And guess what the patient said?
Miracle.
It's a miracle. Yeah.
She said, it's a miracle. Did you ever have patients like this?
Oh, yeah.
And it's like, and I'm like,
Different
oh my
things,
God.
but yeah.
But it was
Yeah.
like, I just thought that was funny because he used the same words.
Right.
So hop up. All right. So I'm going to push this back. You okay here? Okay. 1. We'll do this 3 times.
Okay.
Teeny bit of pain. Okay. That was my. All right. Let's check it out.
Ready? Miracle.
Well, because you're using it, you haven't seen that range of motion. Your Achilles hasn't worked at that range. So what do you guys think?
Miracle.
It's a miracle. You're supposed to say, it's a miracle. That's